Talking about the mobilization of the knee, in particular advanced flexion mobilization of the knee. That was the topic. If we have a patient with a knee replacement, what we have to consider is, after a well done knee replacement, you can expect 120, 130 degrees of flexion. Don't expect really full flexion. No. 120, 130 degrees is okay. What is much more important, that we have a good quality of movement within the possible range. Let's say after a successful knee replacement, you have 0 degrees, maybe 5 degrees extension, and you have this 120, 30 degrees flexion. The quality of that is important. It's not important to have 140 degrees. I don't expect that the patient can sit down here with the knee replacement. Don't expect that. It's not good for the artificial joint to do like this. So quality of movement is important. That means no pain, good stability in the knee, good coordination of all the leg muscles, and enough muscle strength. This is the quality I want to have. So when we have the problem of flexion, maybe we are arriving at 80 degrees, we cannot go further on. Let's remember two things. One, we have to know how was the pre-operative condition and how was the post-operative condition. So when that patient for many years was not flexing anymore, the tissue up here and the patellofemoral joint will be stiff, won't be able to stretch enough for a full flexion. And when the doctor says, after implementing this joint, the patient could move only 90 degrees, don't expect that you can mobilize it further. You will risk to harm the artificial joint. So we have to know. If that doctor says, no, the patient is able to move 130 degrees, I did it during anesthesia, then we know we will be able to do that. So I should know how was it before operation and how was it after operation when the doctor was testing the joint. We should know this data. Now let's think about biomechanics. When I'm flecting, the knee joint moves, so the tibia moves in front of femur, and the patella moves down. So we need a lot of patella movement, downwards movement, this direction. That patella can move down like this. The tissue immediately above the patella, the muscle and the muscle around, the tissue around the muscle, connective tissue, the fascia, they have to be stretchable, flexible. They have to give way to go down here. Plus, the long part of quadriceps, rectus abdominis, has to be stretchable. So this muscle has to be flexible, stretchable enough, and the tissue should not have adhesions and adherence. And that will be very often found. Symptomatically, if you go to 90 degrees, and now I'm forcing a little bit, and I ask, what is your pain? And maybe we'll say, the pain is down here, near to the tuberositas tibia, near at the patellar ligament, here. Then it's always because you are stretching too much here. That means maybe the tibia is not gliding properly, or the patella is not coming down. In a case of artificial joint, it's always the patella which is not coming really down. So it's not coming down, that means the tissue here between trochanter and patella is overstretched, and you get the pain. If you want to be really sure, I go to the moment of pain. Our patient says, I have pain here, and now I'm pushing the patella. And I say, how is it now? And she says, pain has gone. Now I let go. How is it? Pain has come back. This is the proof that tension between patella and tuberosity tibia is too high and gets pain. So if I flex, the pain gives me pain here. It's normally because patella is not coming down enough. So I have to do soft tissue movements up there. Before I'm mobilizing the patella horizontally and vertically and oblique like this, I work here on the tissue. So often we have suprapatellar adherence of tissue, attentions of the tissue, so I do these techniques. Just lift up the skin and subcutaneous tissue. I lift it up from the myofascia and I hold it a bit. So tissue needs time to be stretched. It's not a very pleasant treatment. It's sometimes
just about to ask
it's sometimes a little bit achy and burning pain sometimes. Is it bearable?
Yes, it is bearable.
Okay, as long as it's bearable, it's fine. I lift it up really, here to the side, this direction. Then I'm going in it, I just above the patella, I go in, I hold back, now I give deep strokes like this. I'm stretching.
Is it painful?
Is it a bit painful? Burning pain?
Uncomfortable. It's uncomfortable.
It does sometimes burning sensation. Don't mind, it's okay.
Is this only for the replaced knee or any stiff knee?
Any stiff knee who has flexion problems. Good work. Then you can go in deep and now I really pull it. I pull it up and I do the same downwards as well.
That hurts.
It hurts.
Yes.
So I don't want to trouble you, so just tell me, is it still bearable?
That's bearable.
Okay, it shall be a comfortable pain. If it is a pain which makes me angry, it's not good.
That is bearable.
Patients should like to come to physio so they can cooperate. If they hate to come to us, they don't. They have to like the work we are doing. Then you work on the kneecap itself. The same, you are taking off the tissue like this. And you work below here from the tuberositas tibia, you make these strokes. Just stretch the tissue, because during flexion, what has to be taking place? It has to stretch down, and up here it has to be stretchable here. This part has to become longer, so I'm working on the tissue. Like this too. So always the same technique. Lift up the tissue, hold it, even on top of patella, or you make these strokes with one hand. You fix the tissue, with the other hand you pull the tissue, and you go deep in it. Now, what normally is necessary, you go just along the edge, the border of patella, you hold the patella and then you do circling, you massage the insertion of quadriceps. Very often you find painful spots there, so hold the patella and really go in it. Can you feel?
Yes.
Is it painful?
Well, it's bearable.
Okay. I'm just massaging towards the insertion. Very often you have tender, so painful spots, and this pain is, when you stretch the muscle, is inhibiting. So it's somehow getting a tightness in the muscle. So when you take off this painful spot along the edge of patella, muscle relax better during flexion. So we are working here, and in a non-operated knee, very often we find on the back you have a cyst, a Baker cyst. In the front you have pain, and on the back you have the cyst. It's a very typical pattern. If the patient had for many months inflammation of the joint, normally it develops a cyst on the back. So while flexing, you have that cyst, it will give you somehow discomfort and pain. So work on that cyst. And what you simply do, you palpate, you find the cyst, and then you work like this on the cyst. You are circling and you pushing in. That liquid in that cyst is not thin like water, it's like honey. It's somehow stiff, rigid. So work on that cyst and move, squeeze the cyst into the joint.
Why is the cyst you're talking about? And the popliteal junction.
Yeah, it's normally in the poplite. It can be more on the medial part, more on the lateral part. You just touch with the flat hand and you will feel it. It comes out when you stretch it. And then you work on that cyst, you massage the cyst, you make it a little bit softer. And you will see flexion goes better. The cyst normally has a junction, also has a little fistula into the articular space. So it's filling up with liquid and sometimes it closes. You try to massage it. When it's easing off, and in 9 out of 10 cases, the cyst will empty itself when you massage it and you squeeze it back and then you can flex it.